Hello, everyone, and welcome. So we are starting this webinar today. I'm Dr. Sushant. I'll be moderating the webinar for today. And the topic for today is that we are going to discuss a bit about how the ongoing pandemic, COVID-19 era, how has it changed pulmonary care practice in general, what kind of technological advances we are going to see, or what we are already seeing, what kind of changes we are seeing, how it has changed the practice for most of the clinicians. And of course, we are going to talk about relevance of new technology, new solutions which are available now to the patient and to the doctors, and what kind of application areas are available for the patients. But before we go into the details and before I introduce my panel, what we want to do is this pandemic has thrown a lot of challenges at us in general. It has shown us that there have been fragilities in the system. There are inequalities in the world, how medicine is perceived. There have been systemic failings as well, and that's what we are going to discuss today. But before that, what I want to do is pay small tribute to the people who have been on the front line, who have fought this head on, and who have either come out victorious or have made their names in the history books, not just for medical fraternity but for everyone who is on this side of history. Can we have a small clip, please? It's very important to recognize the efforts of our colleagues, our friends, and a lot of times our family as well, who has been at the front line. And we all know somebody who has been at the front line, being from this fraternity. And I think it's very important that we kind of collectively move together, try and find better ways of how do we cope with such calamities in the future. And that's what brings me to the topic today. And I'm very glad to introduce our panel now. We have Dr. Prabhu Prasad. He's an interventional pulmonologist at Manipal Hospitals in Goa. He has almost a decade plus of wide-ranging experience in pulmonology from CMC Vellore, KMC Manipal institutes like those. Primary expertise, what he's doing right now is, of course, looking at not just acute and chronic respiratory failure patients, patients on non-invasive ventilation. He's also an expert at treatment of patients with diffuse parenchymal lung diseases. Apart from that, there are also procedural expertise in terms of interventional bronchoscopy and thoracoscopic procedures, as well as real-time ultrasound-guided procedures. His primary specialties include interventional pulmonology, transplant pulmonology, palliative pulmonology, respiratory critical care, and respiratory sleep disorders. Welcome, Dr. Prabhu.
Thank you very much.
Our next panelist is Dr. Prabhu Desai. Dr. Prahlad Prabhu Desai. He's a proven fact, a known name in the field of pulmonology. Of course, he's a consultant physician at Lilavati Hospital in Mumbai. And of course, he started his career in Mumbai as well and has been here for the last 30 years. Anybody who knows pulmonology knows his name in Mumbai and I think globally. He has had more than about 50 publications in national journals. He has written numerous respiratory medicine books and has been a fellow member of right from American College of Chest Physicians to European Respiratory Society. And of course, he also has a lot of interest in rehabilitation, pulmonary rehabilitation as well. So he runs a pulmonary rehabilitation center as well. Welcome, Dr. Prabhu.
Thank you.
We also have Dr. Matinuddin with us. Incidentally, Dr. Matinuddin started his career in Mumbai in KEM Hospital, if I'm correct, and then he moved on to Hyderabad, where right now he's a director at Sunshine Hospitals, Hyderabad, since about 4 years now, sir. He has done a lot of work in video assist thoracoscopy and is on acute respiratory distress across different publications and fiber optic bronchoscope publications also we have seen with his name across the board. So those are some of the very little introductions that I'm giving from my panelists. And then anything they want to add, they can add, going forward. We also have Gropinov. I hope I'm pronouncing this correctly. He has been a clinical medicine in clinical medicine for quite some time. He's also a scientific specialist and a key opinion leader based out of Netherlands. Primarily, he's right now also looking at wire for as a clinical scientist. A lot of studies, a lot of research papers, right from exercise profiles in COPD to exercise testing in pulmonary hypertension. He has also done a lot of work in terms of myocardial efficiency and functional improvement in cardiology, cardiovascular systems as well. So I'll leave it to Dr. Herman also to kind of come up with his introduction at a later point. And I think right now he's one of the people who is also working with newer technologies and also has a important role to play as a clinician in the past few years. I'll also introduce Mr. Sushant Rai. So he has been a veteran for the past 30 odd years with GE, and he has worked as a business head for critical care business as well. So primarily his area of respiratory diseases and equipment, and of course critical care. Welcome, sir. Welcome. So that's the panel for today that we have. What I want to do is I want to put a structure to the overall webinar, and then from there we'll take it forward. So what I want to do, everyone, is we'll start with a very basic assessment of your clinical practice in terms of the ongoing pandemic. How have the practices of pulmonary care changed? What kind of technology applications have you seen come in? What kind of solutions have come in newly? How the PFT test protocols have changed, for example. We'll also look at what kind of relevance some of the organizations have played in terms of making pulmonary care easy, accessible, and a little less risky. We're also going to look at long-term impact of COVID recovery patients on for pulmonary function. We're also going to look at long-term impacts of acute respiratory distress syndrome within COVID patients. Then we'll touch on application areas in some specific technologies like impulse oscillometry and infrared technique. We'll also look at what kind of expectations clinicians are going to set going forward. From the industry in general, what clinicians would look for when they're looking at a diagnosis of treatment of respiratory illnesses in the future. And of course, we'll end with a Q&A from the participants as well. So that's the overall structure that I have put to the program today. What I want to do is start with Dr. and bring him in with his thoughts on sir, how has it been, in terms of some personal impacts of practices in pulmonary care? How has COVID really impacted, the pulmonary care as a clinician for you? And then I'll take it across the board.
Initially, there was a lot of panic, and people had misperceptions. Some of the general population were taking it very easy when they were feeling it a trivial illness. They were reporting in a bad shape, and therefore the initial mortality in our place was pretty high. Later on, gradually people realized, and we also started realizing that people can go bad, and we started admitting them and giving critical care facilities early. And the unfortunate thing was, most of the hospitals were not physically and mentally prepared to provide services to so many patients who were requiring respiratory support. So a very unfortunate state of affairs we have seen in the beginning, in the month of June and July, that people were dying in the ambulances, in the corridors, and they were running from pillar to post, from hospital to hospital. But later on, gradually, our system has become gradually robust, and people started taking, even the government setups also got geared up for that. And then I realized that the mortality has significantly come down. As far
Right.
as pulmonology practice is concerned, the initial scare of acquiring the disease, acquiring the infection also has come down slightly amongst doctors, and we realize that proper mask and proper distancing social uh, protects us a lot rather than getting scared of who might touch this, that, everything.
Right.
But one thing is for sure, in our hospital also, even my junior colleague suffered significant illness and he was down with the illness for about 2 weeks. But fortunately, he came out. Amongst my friend circle, we lost 2 or 3 people. But the scenario has significantly changed now. And what we realize is with adequate and good care, most of the patients are coming out, except that people above 65 or 70 years with comorbidities like diabetes, hypertension, cardiovascular diseases, COPDs, the prognosis is still bad in that segment.
Right, sir. So, I mean, that's where I think I'll also bring Dr. Prabhu Prasad in as well. And sir, what has happened is, like sir also mentioned about some of the high risk factor, high risk group patients who still have issues coming out at least, or going to a doctor in general. So, my question to you is, what kind of recourse you think available technology has given you in terms of, overcoming these constraints, whether it is in terms of looking at patients with risk factors, whether it is reaching out to people with the right information. Any thoughts on that?
Well, Dr. Shant, thank you. As Dr. Bhatti Nadine sir told, spoke about the general scenario which we had earlier in our India, and then how it is right now. The primarily the measures which we had to focus is that wearing masks and hand hygiene and physical distancing remains definitely uh, there. Apart from that, I mean, stringent screening and early detection and diagnosis, confirmation of COVID infection, that remains always there. When we see a lot of patients or healthcare workers, I mean, we interact and this thing. So, if you talk about technology or recourse the technology, I mean, the high risk groups like elderly and patients who are on high or extensive morbidity and I mean,
Right.
morbidity diseases. Definitely, instead of, I mean, we can look at into the technologies which can bring, like if you talk about the pulmonary specialty or pulmonary things, we can a lot of newer technologies which can bring the diagnostics into their home or connected care which can bring, and then that can reduce I mean visiting the hospital and spending time in the hospital or healthcare, that can reduce the contact time and then also the COVID infections.
Right.
I mean, if you see a lot of centers, especially European centers or NHS centers, they are stressing more on the home lung function testing or home spirometry or connected care with using smart phone applications or technologies, or
Right.
some of the centers which are practicing on drive home or drive-through spirometries or lung function. And this kind of technologies or recursive technologies if we use, maybe we can reduce a lot of cross contamination of our COVID infection and prevent it.
Right. I mean, that's something that I was, we'll expand on this as we move forward, sir. I'd also like to bring Dr. Prabhu Desai at this point, and sir, you have been, uh, the bedrock in a way. You and Dr. Parker together have been, we've seen you, in interviews on TV all over the place, and you've managed to also, kind of disseminate a lot of positive information about, how do we prevent this situation from going even, any further. Like I think Dr. Prabhu Prasad also mentioned, that we are changing a little bit in terms of how we are looking at patients. We are also looking at protocols a little bit differently. So what I want you to expand on is a little bit about how you see the overall PFT testing protocols change over time, not just during COVID era, but how does it look going forward as well?
Well, I think COVID has a new platform. No, so after that, a lot of changes have happened at every field. It is not only the medicine, but even the other field as well. See, but cutting short, as well as my respiratory field is concerned, okay, I think there is a lot of scope in developing the technology for managing the patient. If you see very carefully, it is not possible to examine the patient when you are having the suit, okay, that PPE kits. It's very difficult to auscultate the patient, very difficult to actually physically examine the patient. So you need a technology here to understand, and just by history and understanding the patient's complaint and just by pulse oximetry, you can get so much information. So in short, if we extrapolate this thing to develop new technologies, I feel a lot of things can be developed. One important thing is that you need a lot of pulse oximeters if you see, okay, and pulse oximeter people have understood also the value of pulse oximeter, value of saturation, value of pulse, okay, 6 minutes walk or walking saturation, desaturation. So much entire world is educated about that. Okay, right. So we need a technology in pulse oximetry, okay, which is probably very easy to monitor. And there are a lot of issues with pulse, with the finger pulse oximeter. You need a better technology. Okay, and we also try to develop something technology in our place, and it is very successfully it is done. Next important thing is that monitoring a patient. Just examining the patient with the stethoscope and auscultating chest sounds. It's difficult during the COVID, and even later on also when you're seeing the critically ill patient, why you should touch the patient for just understanding the breath sounds. Okay, just like you have ECG monitor, can we have a monitoring to understand breath sound which are bilaterally equal or not, whether there are crackles or not, whether there are roncais or not. Those are all things which the technology can solve those problems, and you can non-touch clinical examination, non-touch understanding about the patient can be, in a critically ill patient, which will reduce the transfer of infection from person to person also. So that's possible. As well as you will understand that most of the diseases like asthma, COPD, and even the disease like ILD, okay, what is required is just FVC, FEV1. These two parameters we require actually, okay. And if you have a cost-effective technology to give, instead of picflometer, a spirometer to the patient, individual spirometer, okay, and you can use this app to find out what is FVC, FEV1, including the pattern. Every day, suppose you are monitoring FEV1 and FVC of a patient, it's possible for that, and you can have an idea regarding what is the variation happening, and a lot of softwares can be developed to understand the obstructive, restrictive, and progressive improvement happening or not. And this patient, for that patient did not come to the hospital, in future also. So, and if you see the load of COPD in the country or everywhere in the world, the majority times, this is a disease, asthma, COPD you need actually, and including ILD, because diffusion test is not every time required. What is required is just an FVC, okay. Right. So this is possible. So I think future will be home spirometer. That's what I feel. Okay, that is second. Third thing is probably more important to know is the role of artificial intelligence in all this technology to interpreting, and also the getting a diagnosis. After putting a history on the background, and if you get this thing, you can come to a diagnosis. Okay. By using AI, okay, and it is possible, okay. Even the radiology is also probably will be AI based in future, which already started, but definitely. So this is a platform which is really going to help us. Okay.
I think AI has already been implemented in chest X-ray also.
Yes.
I have heard.
So we need a large data for have a better interpretation.
Yeah.
I think that's what brings me to the next thing, because we are talking about these evolving changes in both technology and solutions. What in general, the general consensus now is that as technology and solutions become better, we'll become better at, like you also said, screening. Diagnosis comes in a bit later, but just the screening of lung health also becomes important, in terms of how do we apply technology to it, whether it's AI, whether it's
lesser
basic.
aerosol generating nebulizers, okay,
Right.
better methodology of getting diffusion capacities of the patient rather than doing it again and again for the good outcome of getting correct values. So these are all really required.
Right. Exactly. So I think at this point, what I'll do is also I'll request Dr. Harman to bring in his expertise and kind of bring us a little at par with how has his experience been as a technologist and as a doctor as well, and just help us understand a little bit more about how do you see better screening and diagnosis of lung health going forward, and what kind of parameters can help us there, in terms of technology and solutions, and what you have to share with us regarding that.
Okay, first of all, thank you for this nice introduction and inviting me, because I'm already kind of learning. And you already explained my background. I was 25 years head of the pulmonary function department in the university in Amsterdam. And 5 years back, I went to, at the moment, Fire Medical as a clinical specialist.
Right.
And I'm involved in trying, and this is the good direction. I think Fire goes that the clinical input becomes more and more important. And then I like it even more to be, I think I'm more close to you than sometimes to the technical department. But to keep it a little bit short, so a few months back we did the interview also because we as a company thought, oh, what is the current landscape? What will be the future landscape? How can we try to be proactive? But
right. These are the questions
cannot
that
be. Now,
yeah.
and what I heard from the other panelists, it's not different that we received back. I received back home monitoring is the way to go, not only for the COVID patients. Like my father is a COPD patient, you don't want to have them in the hospital. But some
Right.
of the people we interviewed, this was
Mhm.
already the case before COVID. But I think it will be in our company. It has more a focus. And I don't want to be that sales here, but we have now the small device with the app and doing the trending. I even gave it to my father to do this, and it's connected to, and it's also, it was from my side. I said, please make it with heart rate and saturation, because then you have a complete picture. And for your information, but you can comment on this. The challenge for us as Fire would be, of course, FEV1 flow volume is nothing new. Home monitor maybe also nothing new. But we received back the big challenge is to get good quality from spirometry at home. So we trying to get this intelligent avatar, because yes, doing 25 years spirometry, it looks simple, but it's not heart rate, it's not saturation. You have to do this nice flow volume curve. So we are now trying to get, or like we are doing now, Zoom or an intelligent avatar in the software.
Exactly.
And the other thing is you can reply or you give me the feedback, but I know coming there, I'm not a medical doctor, more a physiologist.
Right.
The physicians don't want to be, they just want to have the results in a trend. And the PFT technician, I call it, they should be in contact with the patients. That's the feedback. I don't think you want to have all the home monitoring flow volume curve. So this is one. And overall, but this is what I'm hearing here, the studies we received back is like a moderate, just a borderline low diffusion, low spirometry, like restrictive diffusion problem, not really obstructive. And of course, because this is really recognized as an aerosol generating procedure, the CPAP is not that much done at the moment. It's
Right.
also what I heard from you. 6-minute walk is more and more used, of course, because it's simple. And speaking about aerosol generating procedures, they say tidal breathing, like an iOS measurement, is maybe less aerosol generating procedures. But it depends on where we were in the pandemic. The PFT labs were closed, but they are almost back, now not to the normal numbers, but because they have all the precautions, cleaning. So they said to us as Fire, everything you can help with to make cleaning easier, or with the bacterial filters. And what I see, we try to do something to protect our systems, but everywhere they have protected shields between the technician and the patient, not between the patient and the system.
Yeah.
And I as a very long in the field, I can think of. So the people doing the PFT testing in the lab, they have a protected shield between the system and the technician. And the last thing, of course, I can go on and on, but so home monitor, protection shield, a little bit, bacterial filter, but even I recognize, and I was never, even in my trainings, don't use a bacterial filter with CPAP, but I recognize half of the world is now doing CPAP with a filter. And I did some research last week, and I'm in contact with UCLA, Janis Porsas, and they're also doing the testing now, and they see almost no influence on the CPAP values if you perform it with a filter. So we are even trying to find out, of course, you have a little extra dead space, but overall, you can do the CPAP. I have the feeling it goes in that direction. And within our company, we try to get the intent to use for the filter, also for CPAP. This is a little bit, yeah. And so overall, again, I recognize completely what was said here, home monitoring, 6-minute walks, saturation. And it's all where we can help to make the cleaning easier, and the personal protective equipment is costly. This is also what they recognize in the PFT labs. But I can go on for 1 hour, so if I stop here.
I think that's an absolutely valid point that you made. In terms of that, not just the patient-doctor interface, but the patient-device interface also is changing, and I don't think we're going back anytime soon. I think this is an evolving process, and it kind of some of those things will change forever for sure.
Yeah. And the last thing I want to make, it's like regarding CPAP, I think I was also asking this to other people. They all recognize that the people have this moderate borderline PFT results, which do not explain the fatigue problems they have. So you see already multidisciplinary approach, but still they need the CPAP and the PFT results to even show to the patients PFT problems are not really there, but they have problems of fatigue. So there is a big unexplained fatigue, which cannot be explained by the PFT results.
Right. I think we'll take some thoughts on that as well. I think that's an important valid point. Sir, one question I think from the audience that has come in, and I'll just quickly, because it's a yes and no question. Do we have spirometers available to do home screening with the help of mobile devices, as mentioned by you and Dr. Prabhu Desai? We already have connected devices that are available.
Yes, yeah. We have now a new device for 1 year. It's somewhere in between. It's connect to your iPhone, and you have a software for the doctor and a software for the patient at home, and it captures flow volume, heart rate, and saturation.
So what I'll do is quickly also turn to Mr. Sushanta Roy. So what I want to do, sir, is bring you at this point as an industry expert, and kind of get your thoughts on what is because this whole thing essentially was put together by GENWORKS. So what I want to do is bring you in and understand what relevance right now you think GENWORKS is bringing, and what you have seen changing, because you have been working from home, but you've still been connecting online with people, meeting people, kind of trying to understand what the customers have been asking for, almost every day. So what kind of impact or relevance GENWORKS has brought in the pulmonary care in the past some time, and how do you see it going forward in the future? So your thoughts on that, sir.
Thanks, Dr. Thapa, for giving this opportunity. And I would really like to set the context and explain the entire situation. So as you mentioned, GENWORKS. So GENWORKS, I will say, is as an initiative. And rather, I will also say that it is an Indian startup, supported and funded initially by Wipro GE Healthcare, and the mission to dedicate it to improving access, connecting healthcare ecosystems and provide affordable and clinically relevant technology and solutions to clinicians and their patients to all the nook and corner of the country. That is very important, And our solutions include the entire gamut of the services which are available, right from preventive screening through diagnostic to treatment, and catering to all the care areas, whether it's, you mean to say, the diagnostic imaging, cardiology, newborn care, critical care, pathology, you name it and we have it. All the care areas are being touched, and including the the modern intervention like digital health and telehealth solutions catering to these care areas. In fact, Mr. Ganesh Prasad, who is our MD and CEO, believes that our focus should be provide such technology to every physician across India and build awareness about these solutions. This is one. Now, with an aim to provide novel solution to the new normal, now considering the ongoing pandemic, we are now in the process of consolidation. And our foray in respiratory diagnostics is one such priority area. So, where we are offering the comprehensive portfolio in partnership with Bayer, earlier also known as CareFusion, and who are the global leader in respiratory diagnostics. So in respiratory diagnostics, we are offering solutions from simple, handheld devices like simple handheld screening devices like screening of COPD, asthma, CO, or the FeNO technology for asthma monitoring, to tabletop and PC-based spirometry, to advanced diagnostic, solutions like PFT with diffusion capacity, with FRC, body plethysmography, and CPET or cardiopulmonary exercise system with indirect calorimetry, along with the backup service. So this is what GenWorks has a play in terms of respiratory diagnosis.
I think overall, what you've also, I think, mentioned, and it's relevant, I think, to everybody present here and everybody listening, is that a lot of these solutions also are connected solutions, which make them very relevant in today's time. And of course, as they become more mobile, it becomes easy. So I think we're at least covering or addressing those two issues, which is a solution has to be connected. Second is, as we move towards home care, the solution has to be mobile as well. So I think that is something that we're also covering very well, going forward. One more thing that has happened now is, of course, we are 1 year, almost more than 1 year into the pandemic, and what we're seeing now is not just apart from the recent rise in cases, we're also seeing now that there is a growing concern in terms of people who have recovered from COVID-19. But the long-term impact that has happened, over the past some time on them. So what I would do is I'll bring Dr. Mateen again, in and start with some discussion. What we want to also kind of discuss around is pulmonary function, and what do you think has been the some in your clinical practice, the long-term impact on recovered COVID-19 patients, and what the overall experience has been, if you can share, and we can have a small discussion on that as well.
I like to bring in the scenario from worse to the simple.
Right.
We have found cases whom we have ventilated. They recovered completely, but the lungs were so much fibrous that they could not be weaned off from ventilation.
Okay.
They needed lung transplantation, but that's not an easy job over here. And 2 cases like that succumbed in our own unit. One was incidentally a gynecologist who was doing a human service, but ultimately she succumbed. She was on ventilator with us for more than a month, but ultimately she was fully conscious, coherent, cooperative, swallowing, everything was fine, but the lungs were not working for her. So she was the right candidate for lung transplantation, but that was not an easy job. And ultimately, after about 38 days, she succumbed to secondary infections and collapsed with sepsis. That was the worst scenario which I have seen, unfortunately, for a lady doctor gynecologist. And the trivial scenes are more than 70% of the cases are having very mild illness and we are sending them off. But what I realized is I don't have perfect statistic to say, no controlled study to say, but more than 40% of the cases who suffered are complaining even months after suffering. They are complaining of decreased stamina. That means their lung function has definitely got
It's still
affected.
impacted. Okay.
And
Okay.
in practice, we have performed spirometry in number of people, but DLCO and lung volumes in about 79 cases since June. We have done 85 cases, but 79 are post-COVID. And what we
Okay.
realized is there is significant fall in DLCO, means we haven't done prior to the illness. But what we expect, there is significant reduction in the expected DLCO in almost all the cases,
Okay.
ranging from 60% of the expected to even 30% of the expected values. And because we had a impression that this is predominantly a parenchymal pulmonary parenchymal disorder, we were expecting lung volumes to decrease, and lung volumes have been decreased. Out of these 79 cases, in more than 50 cases, we have simultaneously done body walks and lung volumes. And we have found that even lung volumes are significantly decreased. One thing
Okay.
which I was not expecting but happened is there is significant small airways obstruction in almost all the cases which we have seen.
Oh,
Uh,
even long term.
yes, means what's long term? We have started seeing the cases from March onwards.
Right. Right.
So not even 1 year we have completed here.
Right. Exactly. Yeah. Yeah.
So majority of the cases, even if we are doing simple spirometry appropriately, then we are realizing that there is significant small airways obstruction.
Dr. Prabhu Prasad, any other thoughts on this around this? I mean, have your experience been concurrent, or are there any other things that you would want to add?
Well, so if you talk about impact, long-term impact, as we know, it has both physical and mental repercussions, that alters the quality of life of a patient who are recovered from
Right.
COVID.
Right.
If we, in particularly, if you talk about pulmonary function decline after long-term impact on this thing, many studies on these things. I mean, I'm not aware about Indian data or studies. I think most of the studies are not which well structured or followed up for long term. They have seen at the end of even 6 weeks and at the end of 12 weeks, there is a decline in lung function, particularly as Dr. Amin mentioned, predominantly it was like diffusion capacity and also restrictive pattern in the lung function. So, but at the same time, one of the studies they had shown that compared to the first week and at the end of 6 weeks and 12 weeks, there were a little improvement in the lung function. So, I mean, there are positive these things also there, and definitely, I mean, the pulmonary function decline is there, but at the same time, it is kind of reversible when you followed up in the longer time.
So, sir, that was about recovery patients in general, but even the patients who were admitted, let's say, with the acute respiratory syndrome during the during the peak, or came in later and had severe ARDS. What has been the overall impact on those patients? Let's say 1 year hence, or how has been the overall recovery for those patients?
Yes, the impact on the lung function or lung, this thing depends predominantly on the severity of illness. When the patient who were on ventilator, who were in ICU, who are requiring high flow oxygen therapy, definitely they will have a longer impact and longer consequences compared to the mild and moderate
Right. Right.
disease patterns. So definitely patient who had a ERDS, acute respiratory disease, will have a longer consequences, up to 3 to 6 months, sometimes to up to 1 year. So
Right. Right. I think at this point also,
So,
I would.
Dr. Thapa, can I
Yeah.
add something
Sure.
relevant to this topic? So maybe
Sure.
another follow-up query from my side. So,
Sure.
there are evidences to point to the possibility of this pulmonary, fibrosis is also as a long-term consequence of COVID-19. And though the symptoms are found to be typical like any other COVID-19 this thing. And the mainstay of diagnosis in such case is considered to be, high resolution CT or the routine spirometry. So have you also observed, my question to the clinicians or one of them, have you also observed similar phenomena post-COVID in your routine
I think
practices?
I'd go to Dr. Prabhu Desai for the answer, and also because he has been at the epicenter of this situation when a lot of patients are coming in. So, sir, any thoughts on this, sir? What Mr. Sushanta just mentioned?
Yes, obviously, the severe the disease, the outcome of the damage to the lung is going to be severe, and obviously the improvement also will be slower. Now, I can tell you that we have done some significant amount of patients follow lung function test. Okay, first of all, we do pulmonary function test only after say around 1.5 months of his severe illness is over. Okay, and then only we refer for lung function testing to our department. And we have body blocks as well as you can say that your impulse oscillometry also. But what is very important to know is that as rightly said, restrictive disease, there are small airway involvement. There is a lot of patient has got muscle involvement as well, respiratory muscle involvement. Okay, and obviously the DLCO reduction, KCO remains significant number of patients quite normal. Okay, and 6 minutes walk test shows a drop, and on follow up, there's a good improvement happening. So that is not that everything is very bad. Okay, so
Right.
significant number of patients have shown improvement in both
Right.
lung function, in diffusion capacity also. Okay, in 6 minutes walk test distance. What I observed is that generally in ILD, we see when we patient does a walk test, there's a significant drop in oxygen saturation. But that I didn't observe in some of my patients who had a post-COVID lung fibrosis, and when they did a 6 minutes walk test, there was not significant drop in saturation. Yes, they had a diffusion problem, okay, but there was no significant drop. And this was the thing which I observed. Okay, and obviously hyperreactive airways, which we thought about, but we always do post bronchodilators. I have not found any significant great hyperreactive airways in post-COVID lung fibrosis patient.
Right.
So this was, I don't know whether this is universal or only when what I
I think,
observed is correct.
True,
yeah.
sir.
Yes, I would like to just
Similar.
walk in. The
Sure.
thing is, since Prahlad, my colleague and teacher, has mentioned about the muscle weakness, what I realized is whenever we are putting the patients on ventilators, we are giving muscle relaxants and we are simultaneously giving steroids. And
Right.
even after 3 months, when I am doing MIPS and MEPS, there is significant weakness of respiratory muscles too. So I think it is not very clear whether the disease primarily has that impact of muscle weakness, or we as doctors with usage of steroids and muscle relaxants are responsible for that. Because I have not done any study on non-ventilated patients regarding respiratory muscle function. I have planned to do that, regularly measuring MIPS and MEPS in people who haven't gone on to the ventilator. Uh, that means who haven't been given muscle relaxants, but majority are prescribed steroids even if the symptoms are moderate. Whether that is right or wrong, I don't know. It is our lack of confidence that in anticipation of well-being, we are giving steroids. Majority of the doctors are giving steroids to the patient,
Yeah.
even when they have mild or moderate disease.
Yeah, I think that was also a part of the protocol at some point, because most of the ventilated patients were being prescribed steroids. So, Dr. Herman, just a quick, thought from you as well. Uh, because we have now categorized the patients, we looked at, people with, long-term impact of people who recovered from COVID, and of course, people who had severe ARDS going into the disease and, the outcomes. Uh, we have discussed in the past about what kind of patients will benefit from what disease treatment protocols, and how the ventilation protocols were. What I want to know from you is you've done some recent work in impulse oscillometry as well. So I want to know a little bit about the application areas, as well as what kind of these categories of patients that we've just gone through, you think would benefit the most. So if you can just shed some light on that, please.
Yeah. Okay, thank you again. So again, the response what I heard from all the clinicians here is the same. What we received also from the field is that again there is PFT damage. Saturation is important in relation to desaturation detection with the 6-minute walk. And also I heard something about the MIP and the MAP in relation to the patients coming from a ventilator. It's not one kind of patient you see, I think, coming from COVID. And the only thing I wrote down some things that also the feedback we received is that they are restrictive, they have gas exchange problems. And coming back to the difference with interstitial lung disease, we also received the feedback, and this is a question to the other clinicians, that the compliance is different. They still have a compliant lung, a more compliant lung, what we received compared to interstitial lung disease. Coming back to your first, maybe your main question, what will be the clinical value of measuring saturation? And of course, the PFT, you always the PFT testing, like all the volume testing, to my opinion, is always one side of the medal, and it's all about ventilation perfusion mismatch. And of course, we have all nice instruments to measure FEV1, vital capacity, but therefore the diffusion is already in that direction, and therefore I still struggle a little bit with the question, what will be the place of doing an exercise test to find out the weakest link? Of course, this can explain 6-minute walk is low, but 6-minute walk alone can never explain what is the weakest link in the physiological chain of systems, like from ventilation, circulation, the muscles, and everything is mentioned already here. Maybe it's the muscles are damaged, maybe it's the cardiocirculatory problem, or is it the ventilatory problem? And I think at the end, the cardiopulmonary exercise test in total can give you your maybe a direction. What is the problem in this individual in this individual patient? But in addition, therefore, I'm so happy with our home monitoring in doing something in flow volume in combination with heart rate and saturation. Then it's very simple, quick to do. And then you have already something about gas exchange, something about ventilation, perfusion, mismatch, if you include saturation, especially during what is already mentioned here, exercise like a 6-minute walk, because I think we all recognize saturation can stay quite normal if you stay at rest. So it's only a recommendation. It's more like a physiological background, what I see. And that's why, and again, it's not my opinion, it's very important. But of course, I think we recognize this physiological chain where you want to approach from a company as simple as possible, then flow volume, saturation during exercise, during walking, during daily life activities. And at the end, I think you are the medical physicians who want to treat based on kind of clinical evidence. And I think the CPAT test is most, but it's not that easy to do as an aerosol procedure at the moment.
That is
I'll
just a
come in.
follow-up. Yeah, sure,
I'll
sir.
come in.
Please. Yeah.
Since Dr. Herman is rightly telling that we need to evaluate by CPAT, but unfortunately CPAT is a costly test and it is not yet fully standardized with filters.
Mhm.
And
Right.
we were doing without filters till now.
Mhm.
So we restrained from doing CPAT. And even if filters are provided, we need to show to the patient that if the patient has to spend that much amount, because it's a relatively costly test, and we need to justify that so and so studies have proved the benefit like that. So I think it requires few research papers to show benefit of doing CPAT from the patient's point of view or from the parameters point of view, which will help in the management of the patient. I'm sure that is going to come. I'm sure CPAT is significantly underutilized But as a developing country, we find it very difficult to convince the patient to undergo a costly test. Dr.
If
Thakur.
I, yeah,
Just a small, sorry,
I
just a small.
completely agree. I completely agree with you. Even when I was a researcher, I struggled with this 6-minute walk compared to CPAP in pulmonary hypertension. And the clinical benefit is, and even the last feedback I received from 10 key opinion leaders in CPAP, they were different. Exactly like you say, be aware where's the clinical benefit. So I'm of course not telling you this is already proven, or so. If I was the clinic, I would also go for the simple 6-minute walk with saturation and flow volume. And if this is not enough, then maybe somewhere you can use CPAP. So
I think I'll also, want opinions from Dr. Prabhu Desai on this, because I think he also started this conversation around CPAT. So, sir, the question to you is, I mean, it's very clear that there are some clinical benefits over, but is it fully utilized? Firstly, in pulmonary care in India is what I want to ask you. And second, of course, is if let's say I want to increase its clinical relevance in Indian practice, in Indian pulmonary care practice for CPAT, how do we do it? I mean, what's the roadblock in general?
The
Right now?
biggest problem is that the cardiopulmonary exercise test is very expensive. Okay, so
Right.
every hospital may not able to be buying those equipments in the. That's number
Right.
one. And this is we have Mateen knows that we used to have in KM when we were a student, and we were doing the cardiopulmonary exercise test. But in practice, okay, it becomes very difficult to convince the hospitals to buy these equipments. Okay, number one, not every hospital will buy. Second thing is that we need a technicians to train them as well. That's a second important thing, because it is not being commonly used. Okay, we have so many issues with spirometry technicians to train. So the cardiopulmonary exercise test is much more advanced, but there is a great advantage of having, because as rightly said, fatigue and breathlessness are two different things. Okay, and you can diagnose a lot of airway disease, but fatigability, there is no other test to diagnose. Okay,
Yeah,
and
that's what
you have to do a cardiopulmonary exercise test. You have to quantify what is the cardiac contribution in breathlessness, respiratory, and what is the muscle contribution, fatigue, that is disuse of muscles, or you can say deconditioning. So this is a really good, and for pulmonary rehabilitation, so it has got a great role to play. Okay,
Yeah.
so if once your PR centers develop very well, and you have in a hospital PR, okay, definitely will be required. Patient who undergo cardiac surgeries, big cancer surgeries, okay, there the great role is there of CPT. So
Right.
this is an extremely good test. Okay, very nice understanding about physiology. Okay, and oxygen consumption, but being underutilized. The biggest reason is the cost of the machine itself, equipment.
Right. So
Can I
just
can I come in for a while?
sure, sir,
Yeah,
please.
I really appreciate the clarity with which Dr. Prabhu Desai puts forward the things. Uh, but I would recommend, because this is not a very popular investigation and not many places are doing, I think Wire and GenWorks together should formulate some multi-center study so that we come up with a substantial Indian data about the utility of CPAT in various conditions, and especially in rehab, as Dr. Prabhu Desai said. But utility is much beyond rehab. Now, the cardiopulmonary transplants are becoming more and more common, and for evaluation of the patient completely, CPAT is a must. We need to know what is the oxygen consumption of the patient. Similarly, pulmonary hypertension is gaining gradually more and more importance. So, in all these disorders, a properly performed cardiopulmonary exercise test will go a long way. But first, we should be in a position to show to the world and the community that this is an investigation which gives you number of parameters which will be helpful in proper clinical management and further follow-up.
Right.
And the second thing is, uh, I as a center realize that the worst problem with the technician training. It's a costly affair.
Very costly.
I think
Right. Right.
And once you train the technician, they may flee. So these two together, Wire and GenWorks should together formulate a proper training programs for technicians as well as clinicians. Uh, I, as a pulmonologist doing cardiopulmonary exercise testing, I always feel a lot of lacuna in my interpretation. So we do need, as clinicians, a lot of training in cardiopulmonary exercise testing interpretations.
Right.
Can
So I think
can
this
I
is
can I
something.
shortly? Yeah, okay.
Absolutely. So this is something that I want to, encroach upon with everybody actually. In terms of what support industry can
Yeah.
provide, what support clinicians, are asking for. So please go ahead, Dr. Arman, and then I'll go to Sushanta as well.
Yeah, try to. I'm not that good in short answers, but happy to help. And again, I recognize this is also the feedback we are working on to make the application as simple as possible. Last week we had a conversation with an high end, and he said people are turning away from CPAT because they don't get reliable results. And he also, yeah, it's not that easy. If you know it, it's easy, but I think it's a good question. So again, I'm happy I'm here. I will give this back to our within our company, of course. And we always did some trainings for our distributors, or we can do whatever to help. We will. And there was something else about, and of course going. I think by Dr. Martijn Nudin, I think he already knows that it is in guidelines of heart failure, pulmonary hypertension, in COPD, like dynamic hyperinflation. You need to do the CPAT, and they have all these clinical relevant parameters from this. But I recognize it's more costly test. It will take more time, and of course you have to be trained for this. I listen to this, and I'm happy to help. But if I say it's not that simple, but I think it's already a good start that we are now involved in this.
I think that interface is very important. That's
Yeah.
the
Yeah,
other.
that's the most important. We within the companies will not change over day then, but I can only tell you our conversations with the CPAT application goes about try to make it more simple. And even me as an end user, I don't need this complicated. It should be as simple as possible. It's the same for PFT. It's the same for everything should be a little bit easier to use. But this is in the conversations we have, and I'm again happy to be here. We need your feedback maybe for the future to get this working, especially in a big area as you are. It is
I think
important
that
for
that
us.
interface is of course important,
Yeah,
and then
yeah.
once you're committed to something, then we can always find ways to take it
Yeah.
forward. Sushanta sir, your views on this, please.
Yeah, so I just wanted to come in here. So it was a very interesting and educative conversation on this CPET and how to make it more relevant. And of course, the points which emerges is, I think in the Indian context, there is a need to do some case study on specific instances and how it can have some relevant outcome that what we understand. And also the other aspect which comes out clearly is in terms of adequate training, to not only to the clinician, but also to the at the operating level, to the technician level and things like that. On the other hand, as someone mentioned, in the cardiac lab, the cardiac stress test system has become quite an established modality in the Indian context. However, in the cardiopulmonary context is what we have to popularize this thing. And I think in partnership with Wire, GenWorks will work towards the suggestions that we have received on this forum. Thanks. I think I wanted to put it like that.
That also brings me, to one more, important aspect. I think if Dr. Prabhu Desai or has anything to add, in terms of any other, things that you think that clinicians would need in terms of support.
Yeah, I think the other important area is impulse oscillometry, I think, which is
Right.
underutilized tool actually.
Yeah.
In fact, I would like to know from Herman also, okay, how that impulse oscillometry can be used for monitoring ILD, okay, whether it's possible, interstitial lung disease, especially knowing the, you can say that, understanding 5 hertz resonance of the test, okay, whether we can able to monitor ILD.
Right. And Dr. Aman, just expanding on this, I mean, if we can, also talk a bit about relevance of impulse
We all
oscillation.
know about the small airways and the large airways, 5 hertz, 20 hertz. But what about interstitial lung disease? Can we diagnose? Can we manage? Monitor the patient with the impulse oscillometer, because it's a very easy and fast methodology of diagnosing lung disease, especially airway disease.
So as I understand you well, it's a question about iOS.
Yeah.
Yeah. The positive things is it's just tidal breathing. It gives you a distinction between resistance, which is called the big airways. They're not the distal airways, because there is not resistance, because the area is that big. And the reactance value, the reactance it gives as an outcome value on the different frequencies, it can give you the information about the small airways. The drawback, what I recognize also a little bit by myself, so it's very simple to use. You can, even in small children, even there are people using it in animals, so it's that easy to do. But to explain exactly what is happening, so the most simple explanation is we do it on different frequencies, and the low frequency will travel to the complete distal airway. So the resistance or reactance based on 5 hertz will give you the complete picture of the complete lung volume to the distal airways. And we have it on 25 hertz, which will only be the peripheral airways resistance, but also reactance. So the difference between these two will show you information about the small airway disease. So yes, that's the background, which is in addition to flow volume and all this other thing. So it's an additional PFT parameter, which can be very easy. In 10, 20 seconds, you already have all your outcome parameters. But this is always in PFT. You get a lot of parameters back. And what should you do with it? But the main important outcome results are reactance at 5 hertz, resistance at 5 hertz, the difference between 20 and 5 hertz, because this is peripheral or distal airway in interpretation. And you have some other 2 parameters like an area under the curve. So it's the interpretation should be at the end, you recognize a pattern like in the flow volume curve. So you have the resistance graph and you have the reactance graph, and these two together show you a pattern. This is how it should be used clinically. And I can send some interpretation papers, publication to make it as simple as possible to use, which I also use, because this is how it should be done, the
Right.
interpretation.
So just to follow up on that, one more thing that I wanted to kind of wanted you to add here was, during PhD procedure, if you want to create a more efficient diagnosis, how relevant is breath technique? If you can just kind of touch upon that as well, and then we'll get opinions from Dr. Mateen and Dr. Prasad as well on breath technique for PFT procedures.
Yeah, I know this is an intra-breath technique. It's about iOS, because this is tidal breathing analysis. And I think, the big benefit is everybody can do it. And although flow volume, you need some training to do it. And when it provides you some clinical information about the small airways, this is of course important. But if you look at the resistance itself, you don't have it in relation to the absolute volume like a body box. So everything has a pro and contra also in terms of prices, of course.
I think Dr. Sushant is asking about intra-breath DLCO.
Yeah.
Okay.
Yeah. So,
intra-breath DLCO, to my opinion, or if I do it in my training, I think the most important clinical value is you get some kind of cardiac output measurement, pulmonary flow, because acetylene is added to the gas, and because the disappearance of the acetylene is related to the circulation. So you can even use it in exercise, because it's very hard to do a small exercise and keep your breath for 10 seconds. Now you can do submaximal exercise and you inhale and exhale very steady flow, and you get a kind of pulmonary blood flow. So again, for my own research, we used it to estimate stroke volume on submaximal exercise, and it shows a kind of indirect cardiac output, and if you have heart rate, a stroke volume value. So
Yeah.
I don't see the big benefit if you compare intra-breath diffusion to single breath diffusion. I still think single breath diffusion, and again, as a clinician, my opinion is not, but I see from the clinical world and the publications, single breath diffusion is still the gold standard, the 10 seconds breath hold, and that's it. And sometimes you can say, oh, if you cannot keep your breath for 10 seconds, you can lower it down to 8 seconds. I don't see a big benefit
I,
to do it intra breath.
I am sure single breath is standard and accepted worldwide by ATS and ERS. But with the advent of rapid gas analyzers, the intra-breath technique of DLCO is giving equally good results. In fact, it is pretty comparable. We have not done routinely, but very few cases we have done, and it is quite comparable.
But
So,
even again, it's already a few years back. I did the research. I always used an article showing DLCO intrabreath, and there is already an article showing it gives almost the same values. And you can speculate physiology that you do it on a little lower TLC, because normally you keep your breath 10 seconds at TLC level, and now you inhale and you go down, and you have a mean diffusion on a little lower alveolar volume, so you have a little lower area as alveolar capillary membrane. But you are completely right; it's already published that they are very equal to use. But yeah, maybe we need more articles and put it in the
I think
guidelines.
it's
It's
more
always
I
a
understand.
struggle.
as
I
well. Yeah.
understand, but there are a number of patients which we come across because of lack of intelligence or because of lack of stamina. They fail to hold the breath for even 9 seconds.
Hmm.
And if we reduce the time less than 9 seconds, the results many of the times get haywire.
Yeah. No, yeah, no, I'm with you that you can easily switch to the intra breath then, but be aware, we found out the steady exhalation flow is also very important. And I had some people next to me explaining the mathematics and the equations, and then they found out steady flow is a very important thing. But yes, you are right, and it gives you even another. But I maybe my cardio circulatory background and doing pulmonary hypertension research, it was more triggered that I see the big benefit is intra-breath. You can also do cardiac output because acetylene is also in the gas.
Right.
They're
I think
still
it's
experimental.
also, yeah, a little bit of a contextual case. So we'll just quickly, because we have about I think less than 20 minutes left. What I want to do is there are some audience questions that are waiting. So what we'll do is I just quickly wanted to go to audience questions, and Dr. Prasad, I think we can start
Yeah.
with you, and there are some questions that I want you to take as well. So some of the things that people have asked. One of the questions here is, can elderly ILD patient who is stable enough can be followed online by a pulmonologist, and how are we in terms of online follow-ups, because there are different advices coming in. There are people who are saying that pulmonologists sometimes are not comfortable to offer teleconsultations. Sometimes the OPD efficiency, in terms of patient per day, is not to that extent that everybody can get a professional as they need. So, just your thoughts on if there is a stable patient for ILD, can they also teleconsult, and if that will work out for them? If in the not just today, in the future as well. I just need
Well,
this opinion from Dr. Prabhu Prasad and Dr. Prabhu Desai.
ILD patient, actually we usually follow up every 3 months or 6 months like that.
Right.
So predominantly, apart from teleconsultation, I mean, taking the follow-up history, the follow-up will be predominantly focused on the doing CT scans and lung function tests. So, I mean, remotely, definitely these two are at present, and it is not possible. So
Okay.
basically, we'll have to. I mean, if you want to see the progression or these things, you'll have to call them for scans and for lung function tests.
Right.
So little difficult compared to the asthma and COPD patients, where we
Right.
can, I mean, do it with the home spirometry and other things.
Right.
So we are really far from that, for especially interstitial lung disease. I think Sir can expand a little bit
Right,
on
sir.
that
So
part.
I'll just add, for Dr. Prabhu Desai, I'll just
Yeah.
add another part to this, sir. So
Yeah.
there are someone in respect to this also asking, what are the instruments for monitoring, enhancing lung capacity, oxygen saturation that patients should keep at home, and maintain a record to be shared with pulmonologists in ILD cases? Is pneumonia vaccine advocated for ILD patients? Please suggest any regime. So this is one question, but if you can break it down, that's absolutely fine, sir.
Yeah, first of all, yes, we have learned in this time of COVID to monitor the patient and examine the patient also by on web consultation. Okay, and this is one of the best method. We have to improve the technology. That's what I feel. It's so
Right.
comfortable for the patient of an ILD to remain at home and give us information regarding his condition,
Yeah.
especially follow up. I'm not talking about the first case when you have seen the patient, when you have examined the patient, you have seen the scan, and you have given a diagnosis to the patient. For regular follow-up, bringing them to the hospital is actually criminal nowadays. Okay, it's very difficult. So
Right.
we have to have some technology for them to understand. Okay, either questionnaire-based technology where we can come to know their progress, their possibility of the overall their lifestyle, whether it has really affected or not. It's not difficult. Okay, it's possible. Third important thing, pulse oximeter. Now they are well aware of it. They are all aware of about the walking test and walking desaturation, step desaturation. Okay, we can have even a technology of a 24 hours oxygen saturation monitoring for them to understand percentage drop which is happening to overall the period of time. So it is possible to know the regarding pulse rate. Also, they can give information. Blood pressure equipments now everybody has at home. So
Right. Right. Right.
vital data is possible. Okay, number one. Second, even a good camera if the patient has, and a good sight if you have, you can even inspect the patients very well. Okay, I don't know, there is, you can't auscultate, but these are the ways you can understand whether my patient is stable or not. One, whether he is likely to have infection or not. Third, whether he is in failure or not. That also you can find out. Okay, so it is possible. You need little more good, you can say, sturdy equipments and good facilities to understand, but very difficult to opine on the new patients. That's number one. Second thing is that video consultation is difficult. Number, it is for consultant. Okay, it's easy for the patient. Why it is considered? It takes time. Okay, in 2 minutes you can make out the patient when they come to you in a clinic, from when they open the door and they come and they sit on the chair, and when they talk, I come to know out their respiratory system entirely, and just putting pulse oximeter and BP, I know everything. But this judgment you don't get, when patient is there at home. So these difficulties are there, but I think for follow-ups we can use this technology.
Dr. Prasad said one more thing that some Amit has asked. He's asking, again, it's a two-part thing, so I'll just put it to you, and then we'll come Dr. Prabhu Desai as well. Have you witnessed any ill effects on patients who have had their PFT appointments cancelled or postponed due to the pandemic? And then, and if so, what is your takeaway for your fellow clinicians and I think other RTs? Is what he has asked. The other thing he's asking is, how do you think companies dealing in respiratory diagnostic equipment can be of help to clinicians and patients apart from their regular practice of providing diagnostic tools? I think this has to do with technology as well, but also what he's asking is, if there are patients who have had their PFT appointments not go through and cancelled one, were there any significant ill effects, and overall mortality or overall morbidity, how it changed. I think that's what the question is.
Yeah, lung function test, when the patient phone for the PFT, they have to go through a lot of things. Like, for example, the history of whether they have infection or not. That's number one. Okay? Especially now, any small fever, 1 day history of fever, also you are stuck. Okay? Earlier, it
Right.
was not there like that. Okay, we used
No,
to
it's
take patients.
yeah. Now it's anxiety. Yeah.
Yeah,
Not,
so
yeah.
fever history. So patient is screened at before appointment also and before the test also. So that's one. And even the family history of having a fever also is very important over here. So these are the things which, so that many times appointments are cancelled. Yes, I agree with you
Right.
regarding the test. And even if the suppose I refer the patient from here to some other hospital, those people they don't know about the patient at all. Okay, so they are in the more difficult situation. But when I refer from my hospital to my PFT lab, the technician will easily able to take the patient for and do the
Of
lung
course.
function. So suppose I refer from Kokilabin hospital from my clinic. Okay, since people know that I am practicing and I'm refer the patient, that's okay. But suppose a general physician refers for a lung function test, it's difficult for the PFT technician to take a call. Okay, and they
Absolutely.
routinely do the COVID throat swab test. Okay, for all these patients before they subject for the pulmonary function test. So these issues are there when they cause more complications. Okay.
Right. So there's a specific question for Dr. Mati. The question that Manish is asking is, for lung volume measurement during COVID-19, what would be the ideal device?
Body box is the gold standard for doing lung volumes. But body box is not available at many places due to the cost factor.
Right.
And if we are doing DLCO, that also can give lung volumes to a certain extent. And with rebreathing also, we get good volumes. But if we suspect that patient is suffering or COVID positive, then we are not doing any test at all.
Right.
And if we are doing, then nothing like body box.
Okay.
Less
Okay. I think that's
aerosol generation. You can clean the body box.
Yes.
So
sure.
actually speaking is really good for even your Spyro you can do in body box.
Right. So, sir, what I'll do is, because we have about, I think, 7-8 minutes left, and I want your, final words on, from each one of you. I'll just request Mr. Sushanta to come in and, also, kind of give us a little bit of, sneak peek of how, going forward, how do you see, the collaboration, as well as the, how do you see, both the clinicians and, medical devices, people coming together and kind of collaborating on the efforts? Because I think this is very clearly thrown open a lot of, questions that how do we collaborate and, in terms of technology and in terms of, patient outcomes. So just your thoughts, sir, and then we'll take a, I have a final question that I've kept for the ending that I'll take thoughts on from everybody. Mr. Sushanta, sir, please come in.
Yeah, great. So thanks again for your question. So, I would take the opportunity to lay out the concept, context. So coming from trade and representing GENWORKS, what we have seen when we have evaluated the market, if you look at the market here, except for direct presence of about one global company, most of the other global companies, one or two, are represented by dealers who are active in certain pockets. And apart from that, there are some local manufacturers. Now, this is the current situation. Now, what GENWORKS, in partnership with WireA, provides comprehensive solution for entire profile of pulmonary care and addresses three concerns. Number one is that on standardization. So I know most of the local manufacturers, they don't have any regulatory approved products or standardization, whereas WireA has about 60 years of experience in the respiratory diagnostics portfolio. So, and all the products are US FDA and C approved. So it is a standardized product. Second is that GENWORKS as a company provides your holistic solution with a single window approach. So considering pulmonary diagnostic, pulmonary care as a modality, if you look at whatever the technological interventions which happen, so right from the elementary intervention of a chest X-ray to CT and to bronchoscopy to ICU ventilator inside in an ICU to, of course, the respiratory diagnostic portfolio we have now. So all these solutions are there. Apart from that, even the pathology side, the relevant tests which are done, right from clinical biochemistry to the routine hematology and all tests, all these solutions and devices can be offered by GenWorks. So this is a single window solution that we're offering. None of the other companies are in a position to offer that. Not to mention about the digital and connectivity solution which connects the various ecosystem, and these are all future proof in terms of future requirement. And apart from that, important thing is that GenWorks also has an e-commerce portal to take care of the sourcing of disposable accessories, even pharma items at a very competitive rate, and which provides also hassle-free experience. So this is the, as I mentioned again, holistic solution with single window approach. And finally, it's about access and reach. So, again, GenWorks perhaps is the only company in India which provides access to the entire country. So with a team of over 400 members located in over 140 locations and covering over 700 districts. So, and we are ever ready to respond to the needs of the clinician partner. Our three-pronged approach, we will be able to create awareness and build sustainable partnership with the pulmonologist community in the larger interest.
Can I come in, Susanta?
Yeah, sure.
Yeah, you are from the trade, and I believe in one thing: supply creates the demand. And here, not only supply, the ease of supply is one thing, and the training of the personnel is another thing. DLCO is there in the market with various companies, but frankly speaking, heart of the heart, many pulmonologists themselves, they don't have full confidence that DLCO will be done appropriately and they will get some important clinical values out of it. Though they ask for it, but from very few places they get a properly done DLCO, if Prabhu Desai agrees with me. And that has brought a bad name on such a wonderful investigation like DLCO. And same will happen if the personnel are not trained properly for doing impulse oscillometry or for doing body box or CPET. Since you have come up taking responsibility to supply these things all over India, I am sure you should concentrate more on how ease with which you can supply and how more and more number of technicians and clinicians can be trained by you in coordination with YAIR. And that one thing, if you take it seriously, I think you have a huge market in India.
Right. I think that collaboration is
Great
definitely required.
suggestion.
Right. So, sir, because we have about 2-3 minutes left, what I want to do is pose, final thoughts with this final question that I have, and I'll, request each of you to come in for a minute each. The question is in 3 parts. I'll just quickly read it for you. What will be the impact of human lungs in COVID-19 situations in the air polluted areas in India? What are the precautions in the higher level of air polluted areas, higher levels of air polluted areas that people can take? Apart from lungs, which organs of human body COVID-19 can impact in present and prolonged time? And lastly, will COVID-19 impact our next generation? So I'll leave this floor open now. We'll start with Dr. Prabhu Desai, and then we'll take it to other people as well. A minute each.
I think from the after the lung, okay, the next important thing, organ is probably, I'm not talking about a heart and the kidney, but it's mind. Okay, I think the most important thing is affecting the mind of the people. And I'm telling you honestly, that impact is going to be huge. Okay, and obviously, not only the people who have suffered, but the families, who had a COVID, and families where their casualties happened. Okay, that their mind is really, this impact is going to be there for 25, 30, probably a generation, you can say, or maybe more. We don't know. But that's one. Second thing, as well as the pollution part is concerned, and the this thing is concerned. I don't know honestly, but people are now well concerned about they are concerned about the
General hygiene
bacteria,
and
viruses, and all. So the
yeah,
use
yeah,
of mask and all hygiene, especially India.
absolutely.
I mean,
Yes.
there will be a great impact because 100% hygiene is going to improve in all levels. Okay,
Right.
no question about it, and we should continue that. Whatever happens to COVID, that will. We must continue. We must promote. We must talk all the time about the hygiene, hand hygiene, and mask hygiene. Okay, so
Fantastic.
that will help us a lot. Okay, we will be a different country in next 5 years, 10 years.
Fantastic, sir. Thank you so much. Dr. Batin, any final thoughts?
Yeah, as Prabhu Desai said, we have come across massive cerebrovascular accidents in our patients second to lung, and we did come across significant myocardial infarctions and congestive cardiac failures, not because of complications of mechanical ventilation or multi-organ failure. We have seen isolated myocardial infarctions in spite of not having any hypoxemia. We
Right.
have seen significant number of cerebrovascular accidents. I have seen one case, incidentally, of a doctor again, who had almost healthcare involvement with infarct. These were quite unusual cases which we have come across, because incidentally, I was seeing somewhere around 70 to 100 cases per day in the whole era of past uh, 8 to 10 months, and it was really scary at some point of time.
Right. It was for
Uh,
everybody. Yes. Dr. Prasad, any final thoughts?
So air pollution, as we know, I mean, it has got at least similar or a greater impact compared to smoking history.
Right.
Particularly mixed with COVID, we have seen a severe COVID illness in predominantly patient who had smoking. So definitely, it has a double impact on the lungs when a pollution and then COVID has seen. And apart from general this thing, we have to focus mainly on the prevention of air pollution and following the wearing mask that has to continue
Continue.
apart from the general.
Fantastic. Dr. Herman, any final thoughts? And also the question, the last part of the question, what are future generations going to be impacted by COVID-19?
Yes, the last one. I do not hope so, but what I see,
Yeah.
there will always be a virus, so we have to deal. So maybe when this is going over, so the most important thing I want to say here, I'm so happy that I was invited, and I hope for the future I'm invited again. And the last talk, the last reply from Dr. Martin Nudin, I really hope, but I will put the effort in. The feedback I received is that people's you need training, you need, and I'm from that side. I'm from quality. I'm therefore I'm coming from the field. I understand that's the nice part of our work is you need some knowledge to get the patient do an excellent test. If I could help tomorrow, then this would be my best. But I'm so happy that I'm invited here, and let's continue this cooperation. I'm really hoping we can manage this, and even I do it really for the patients. My
Right.
feeling is that I think we can help there, because nice instrument is one, but yeah, you should use them properly. And of course, at the end, it's good for via sales and everything. But still, I do this for 30 years now, so I'm again repeating myself. Happy that I'm invited, and I'm
Right.
even more excited afterwards. And
Right.
hopefully, we can help each other.
I think on the level of practical collaboration and concrete steps. Sushanta sir, any final thoughts?
Oh, I think on the clinical aspect, it has been, very ably disseminated by the clinicians, distinguished panelists here. I take this opportunity on behalf of the trade and GENWORKS just to thank again, especially the pulmonologist and the intensivist who had been leading the fight against COVID over a year. And I mean, hats off. There is no words which can be sufficient to thank for all that we have been doing over the past few months. And the battle continues. So that is this part of it. We hope that vaccine will come in soon, and all of us will be inoculated with that, so that we can go out with our daily business smoothly like before. So this is one. And the second point is in terms of lot of valuable suggestions we have received from the various August panelists, and definitely it will be our task cut out to work on this to ensure that we build upon this partnership to get the benefit across to the patients across the country.
My 2 cents are only that wherever we are, what is somebody who is in a medical, all looking to improve patient outcomes. That's it. We all work for that day in and day out. Everything else is secondary. It's probably more spreadsheets and clinical practice and patients improve clinical outcomes for the patients. A patient comes in with a distress, with a problem, with pain. He has to go back feeling better. I think that's what we work for, and I think what we want to do is also with this collaboration achieve that one single thing and make it better going forward. So with that thought, I think I'll thank all the panelists for joining us today. It has been a very fruitful discussion. Hopefully, we all learn something new, and also thank you to all the people who have been there with us and have asked questions to us. It's been fantastic, and I hope we'll meet again. Our paths cross soon. And thank you so much all for your making time for our conversation today.